and I left you the parole.
Sí, sí.
Bueno, finalmente hemos logrado superar los problemas técnicos que habíamos tenido. Entonces, para mí es un placer presentarles al profesor Francesco Giammarile. Él es médico, especialista en medicina nuclear, doctor en biología física y con formación de posgrado en oncología, pedagogía, medicina hiperbárica y física nuclear. Actualmente desempeña un rol central en la Agencia Internacional de Energía Atómica como Senior Technical Officer, liderando iniciativas para el fortalecimiento de la medicina nuclear en países de ingresos bajos y medio. Además, es profesor titular de la Universidad de Lyon, en Francia. Su experiencia incluye imagen híbrida, evaluación de ganglio centinela y terapia interna vectorizada. Es editor en jefe de la European Journal of Hybrid Imaging. Para nosotros es un honor contar con su presencia. Su conferencia aportará una perspectiva científica y práctica de gran relevancia. So, I give you the parole.
Sí, muchas gracias.
Go ahead.
Voy a hablar en español solo por esta diapositiva, que es un placer de saludar a todos mis amigos en Bogotá. Lamento no poder estar con ustedes, pero y también la problemática de la técnica está, pero vamos a lograr. Entonces, la segunda diapositiva, por favor, es la presentation outline. I will speak first about a short introduction about the FAPi in infection and inflammation, then cardiovascular application, neurology, other emergency areas, and therapeutic potential, and then conclusion. Next, I have no conflict of interest in this setting. So next slide. In non-oncologic disease, I think that FAPi biology is rather the same as what you have heard until now about oncology, since it's always the same transmembrane serine protease, strongly upregulated in activated fibroblasts, in this case during tissue remodeling. And there is very low expression in most adult quiescent tissue. That is a good contrast also in inflammation and infection. And the key contexts of upregulation are wound healing, fibrosis, chronic inflammation, and of course, tumor. Next slide. This is an example I think you have already seen of classical FAPi imaging. Just for the interns, you see that you don't see the brain like FDG, so you can make a good you can realize in one moment if it's FDG or FAPi. Next slide, please. So the pathophysiological basis of FAPi uptake, we have the activated fibroblasts that are present in a wide range of conditions: chronic disease, tissue remodeling, fibrosis, and chronic inflammation, as said before. Actually, there are myofibroblasts in fibrotic organs like lung, liver, heart, kidney, skin, that are the major contributor of FAP expression. And then we have also perivascular and advential fibroblasts that can play a key role in vasculitis and atherosclerosis. Of course, I will not speak here about the cancer-associated fibroblasts. Next slide. This is the example with the activation protein through activated fibroblasts and the different tissue like arthritis and inflammation, fibrosis and infection, tissue remodeling and repair, and then some normal tissue like mammary glands and endometrium. Next slide. So what are the clinical unmet needs FAPi that FAPi could address? First of all, it will be able to differentiate reversible inflammation from fixed fibrosis. That is a major challenge in many chronic diseases. It can predict early treatment response in inflammatory or fibrotic condition, and then it can improve risk stratification, for instance, in cardiac remodeling, progressive interstitial lung disease, or rheumatoid arthritis-related joint damage. We will see all those cases later on. What is also important is that it can guide and monitor new therapies, including anti-fibrotic drugs and emerging FAP target treatment. So we come back to what Adriana said before about cancer. Next slide, please. If we compare FAPi to FDG, of course, there are two different biological signals. You know that FAPi is fibroblast activation and matrix remodeling, while FDG is the metabolic activity of inflammatory and immune cells. However, FAPi has the advantage of having low background in several key regions, especially for inflammation and infection, like heart, brain, and bowel. The patient preparation is simpler. I remember the nightmare that was to have cardiac FDG uptake as low as possible. With FAPi, we don't care. Then we can say that there are also complementary information. The both exam can be done together. And what FDG has not is, and what I said before, Adriana, is the theranostic possibility of FAPi labeled with lutetium or actinium. Here, this I think you have already seen this image, is the comparison between FDG and FAPi, but in oncologic situation. We will see later on some inflammation situation. Next slide. So what are the limitations of FAPi? Always speaking about non-oncologic diseases. I think that the experience is very limited. In the literature, we can see only single center observational studies or some meta-analysis. Those studies, moreover, have significant heterogeneity because the traces are not the same. They can use FAPi 04, 46, or 74. The activity are not the same. The timing of imaging are not the same. The type of reconstruction. So the metabolic parameters like SUV cannot be very reliable compared. There is no standardized interpretation criteria or reference thresholds. So in conclusion, I may say that it's a promising technique, but there are heterogeneous results, and clinical decisions should always rely on established standards. So for the moment, it's not the clinical aspect of FAPi in non-oncologic disease. It's not the same as in oncology, I would say. So let's start first, FAPi in infection and inflammation. So the fibroblasts became activated in chronic inflammation, granulation tissue, and abscess walls. The FAP expression is reported in rheumatologic diseases, vasculitis, atherosclerosis, plaques, and chronic infection. There is only current evidence and isolated case reports and small series, not ready to replace leukocyte or FDG studies, but potentially complementary too at this stage. Next slide. So the differentiation between acute and chronic inflammation. In the acute inflammation, there is dominated by immune cell influx. Therefore, fibroblast activation may be delayed or modest. On the other hand, in chronic inflammation and tissue remodeling, there is strong and more persistent FAPi uptake. So FAPi can make the difference between these two aspects. The combination in this occasion with FDG can help time-stage disease activity. If FDG is high and FAPi is low, we have cellular inflammation. If both are high, this means that it's a mixed inflammatory and fibrotic activity. If FDG is low and FAPi is high, it could be active fibrosis. Next slide. So the first case we can see is the inflammatory bowel disease, like Crohn's segment or differentiate inflammation from fibrosis. That is very important in those patients. We can see next slide, the image comparing FDG uptake and Crohn's disease or ulcerative colitis, FDG and gallium. You can see that the difference of uptake in Crohn's disease and in colitis, it's evident. In the first setting, we have low FDG uptake and high gallium uptake. In the second, we have high FDG uptake and practically absent gallium FAPi uptake. Next slide. Another aspect can be represented by arthritis and inflammatory arthritis. The synovial synovial fibroblast activation is a key driver of chronic arthritis and may serve as a marker of disease activity and treatment response. So I think it's maybe one of the most important aspect is the treatment response. Nowadays, the treatment of arthritis are expensive. I think it's a good aspect to do with FAPi. We can have baseline FAPi and then early response to therapy. The problem, like always, is that we have a small cohort, maximum of 50 patients, primary and rheumatoid arthritis. We have some data in psoriatic arthritis, ankylosing spondylitis, spondyloarthritis, and degenerative joint disease that are emerging but not yet. Next slide. Here we have a comparison of patient before and after the treatment of rheumatoid arthritis, and you see that both FDG and gallium can show easily the disease remission. Clearly, with a baseline gallium FAPi, much higher uptake that give us more confidence in answering that it's a good responder, at least in the shoulder and other joint, but not in the wrist. Next slide. This is another case of treatment evaluation, but in spondyloarthritis, you can see that the response is complete in this case with gallium FAPi. Next slide. Another possible indication is immunomediated and autoimmune systemic disease, like sarcoidosis, autoimmune pancreatitis, chronic fibrotic lesion. In this case, there is high uptake in affected organs and may outperform FDG in some location. What is also interesting is in the disease that is called immune-mediated inflammatory disease, FAPi signal correlates with early fibrosis and clinical severity. So it's very interesting to give prognosis to those patients. Next slide. This is an example of sarcoidosis, and you can see how high is the uptake of gallium in multiple muscle lesions. Next slide. Now we move to wound healing and other application. For wound healing, there is intense FAPi uptake in recent surgical scars, anastomosis, and chronic ulcers. And this also in this case, FAPi may serve as a biomarker of impaired healing. What is also interesting and is a link with oncology is the radiation-induced fibrosis. We can have persistent FAP signal before CT detectable changes, and this highlight early tissue remodeling. That is an interesting information in radiotherapy. Then we have the chronic skin fibrosis like scleroderma and radiation fibrosis that are potential target for FAPi imaging and therapy. Of course, longitudinal data are limited because of small cohort and recent article. I think that further studies are needed to map dynamic fibroblast activity. Another application is musculoskeletal application, like chronic tendinopathy and enthesitis, that shows actually FAPi uptake and may have a role in sports medicine. And this is also a very good, I think, door that is open in situations that are sometimes very difficult to treat. This is an example of a scar repaired after bilateral inguinal hernia. You can see before and after some days that the signal is reduced, showing that the reparation was in line with the situation. Next slide. We move to infection, chronic osteomyelitis, prosthetic joint infection, chronic soft tissue injection are the indication. Of course, also here in this case, we highlight the fibroblast-rich granulation tissue rather than acute neutrophilic abscess. It's particularly used when FDG is not specific or show high background like spinal hardware or prosthesis. In case of prosthetic joint infection, the inflammatory rim can be detected, and we can decide a post-osteoarthropathy case. Another possible indication is in tuberculosis and granulomatosis disease. We have uptake in chronic fibrotic granulomas and might serve as a marker of disease chronicity. This is the example of prosthetic joint infection with FDG and with gallium. Now we move to cardiovascular. What is very interesting is that with FAPi we can visualize the remodeling and fibrosis, like in cardiac after myocardial injury, like acute myocardial infarction, chronic heart failure with diffuse fibrosis. The early post-MI peak indicates active fibrogenesis, and uptake decreases as scar matures. In cardiomyopathy and heart failure, there is global or regional uptake that correlates with adverse remodeling and risk factors. There is a potential role in early identification of patients at risk for progressive remodeling or arrhythmias, and may become a tool for monitoring post-MI remodeling and assessing therapeutic response. Also, in post-interventional change, it can detect fibroblast activation after ablation or device implantation. Finally, it's useful for monitoring tissue response following cardiac procedures. This is an example of myocardial infarction. You can see with the gallium FAPi above and with FDG under. In this case, FDG show a complete absence of signal, while the FAPi shows a positive uptake. Next slide. Specific indication in cardiovascular are hypertrophic cardiomyopathy, myocarditis, including checkpoint inhibitor associated, light chain cardiac amyloidosis, and this is a very interesting setting. I know that in nuclear medicine there are a lot of recent study in amyloidosis, and FAPi could play an interesting role in this case. And then also in cardio-oncology, if we are following the functional decline in anthracycline treated patients. Another indication are vasculitis, aortitis, and large vessel disease. In this case, we have only case report, and I have only seen some preprints, not full article. However, theoretically, FAPi may delineate fibrotic vascular wall change beyond FDG positive inflammation. There is a possible role in monitoring progression from inflammatory to chronic fibroblast stage. And then, of course, the data are limited. We have comparative study versus FDG and MR, and these are, I think, needed. We can also see atherosclerosis activated fibroblasts in plaques, and we can identify unstable or inflamed plaques. This is an example of systemic vasculitis with practically no sign in FDG or very tiny, and a clear sign in gallium FAPi. Next slide. For neuroinflammation and gliosis, we have a normal brain uptake that is contrary with FDG. So we have an excellent contrast for glial or fibrotic. In animal study, we have a FAPi that can track cerebral fibrosis after ischemic strokes, and the uptake correlates with collagen deposition. In early human studies, we have gallium FAPi uptake that is what was observed in acute infarcts, including lesion at risk of hemorrhagic transformation. Therefore, there are potential application in monitoring post-stroke scar, in assessing neurotrauma or brain remodeling, in characterizing chronic multiple sclerosis plaques, in studying chronic post-ischemic gliosis, and finally, why not, exploring glial scarring in Alzheimer's disease. However, the evidence remains very limited and largely exploratory. This is an example of fibrosis after stroke. The red arrow shows you the fibrosis. Next slide. A very interesting, I think, application could be the interstitial lung disease, especially in those days with COVID fibrosis. FAPi can demonstrate high uptake in fibrotic lung disease. And we can also see post-COVID fibrosis. And I think that also therapy monitoring can be a good indication in this case. Next slide will show you how big is the uptake, much bigger than FDG in the left. In the right, you have the gallium FAPi. And I think that the therapy evaluation in those patients can be done really in a best way with gallium FAPi than with FDG. Next slide. Finally, liver and abdominal organs. FAP expression is increased in hepatic stellate cells and fibrotic septa in chronic liver disease. It can also therefore show heterogeneous uptake in cirrhotic liver, in nodules, in portal area and cholangitis. Potential application non-alcoholic steatohepatitis, portal hypertension, post-transplant. Other organs, eventually renal fibrosis and pancreatic fibrosis. This is an example of portal biliopathy, and you can see the lesion in an easy way, with a very good contrast to normal hepatic tissue. Next slide. We move now with the theranostic potential. There is a rationale for TAP target therapy in benign disease because there is a high density of activated fibroblasts, and the possibility of transforming FAPi in a therapeutic agent it has been shown in therapy, in tumor therapy. However, there is a problem in normal patient, and essentially we have to be aware of the excessive fibroblast ablation may impair normal tissue repair or weak organ function. This is something that has been unexplored. Therefore, this is just anecdotal and not real therapy like Adriana showed you. Next. So the therapy indication, of course, you can see in the theranostic classic. Next slide. So what are the possible indications after myocardial infarction and heart failure? In case of progressive fibrotic pulmonary disease, in case of advances rheumatoid arthritis, and inflammatory arthritis, and in case of severe organ-limited fibrosis, like radiation-induced fibrosis, chronic pancreatic, and liver cirrhosis. You see that is all those indications I already show you images, because they are the case where the FAPi, pathologic FAPi is very high, the uptake, and so maybe the therapeutic efficacy is also high. Next slide. So the classic theranostic approach is adapted in oncology is the one that we do, gallium replacing, lutetium or actinium replacing gallium or fluorine. There is a preclinical evidence in rat models that is experimental, and the future vision is eventually FAP target CAR-T or CAR macrophages or combination strategies with anti-fibrotic drug. This could be also a good idea, but for the moment they are only theoretical and not real aspects. Next slide. However, I must tell you that Novartis in 2021 already bought a license for compounds targeted FAPi, thinking on the possibility of doing not only diagnosis but also therapy. Next slide. In conclusion, for this diagnostic potential, the current status is really very limited. We have safety concern. we have disease heterogeneity, and we have, most importantly, regulatory and ethical issues, because we are treating benign condition, not tumors. Therefore, we are really the primum nocere is really the big aspect to be considered. Next slide. In conclusion, we need for FAPi multi-center prospective trial with standardized protocols. We need longitudinal studies linking FAPi metrics to hard clinical outcomes. We need comparative study versus FDG, leukocyte imaging, and fibrosis MRI. We need theranostic strategies eventually, and we need multi-trace and maybe multi-tracer and artificial intelligence may improve this aspect and help us in this difficult for the moment The ultimate goal is to shift from structural scar description to real-time molecularly guided fibroblast modulation. This is really the dream. In take-home message, FAPi-PET visualize activated fibroblast. Beyond oncology, we have robust signal in pulmonary disease, cardiac disease, rheumatology, infection, and chronic scares. There is a theranostic potential, but it remains largely experimental. Key challenges are related to disease heterogeneity, safety, dosimetry, and regulatory condition. The future direction is multi-center trials, longitudinal studies, artificial intelligence, and multi-trial integration to move from scar description to molecularly guided therapy. Thank you very much for your attention. And I don't know if there are questions or what should I do. Thank you.
Thank you, Francesco. As always, an excellent conference.
Oh. Okay.
Vamos a pasar por el auditorio. Si alguien tiene alguna pregunta para nuestros expositores. Okay. We start asking the question in Spanish. Is okay with you?
Sí, entiendo bien. No puede hablar muy bien, pero entiendo, sí.
Ok. Para fibrosis pulmonar, ¿este es pronóstico, el FAPi es pronóstico y con algún sub o solamente para saber si hay fibrosis nomás?
Sí, el sub I will speak answering in English. Do you mind?
It's okay.
So the studies, of course, some studies are speaking about SUV, but the problem is that different studies are not relating the same measurement. This is true also for FDG if you want, but for FDG we have much bigger number of data, and now we are a little bit more confident. But with the small cohort with the FAPi, I think that the SUV is really not reliable. Maybe as institutional measurement, it could be interesting, but not as a clinical parameter.
Okay, I have a question. Here in Colombia, we have GallioFAPi, but there exists other option to synthesize the FAPi is with the fluorine. So in your experience, do you have a difference between GallioFAPi versus fluorine FAPi, or is the same? And what is your experience about the production of fluorine FAPi? Is easier or they have more challenges than GallioFAPi?
So the first thing I was surprised that the title of the presentation was Gallium FAPi, because of course FAPi is not only gallium, is also fluorine. And we in my university we started with gallium, and now we moved to fluorine, because the problem of gallium is that the generator is expensive. And now we have more and more patients with neuroendocrine tumors. Therefore, the demand of the cyclotron, the demand of the generator is really all directed to the patient who has neuroendocrine tumor. So we do gallium dotatate. as we must. No, you know that we have to do this. For the difference between gallium FAPi and fluorine FAPi, I think there is absolutely no main difference. It's not like PSMA, where we have really a big difference. But I think that the difference is not related to the radionuclide, rather to the FAPi molecule. For PSMA, the PSMA was not exactly the same, I think, and therefore we have no urinary expression with the fluorine FAPi, so that is much more interesting to use fluorine FAPi rather than fluorine PSMA rather than gallium PSMA. For FAPi, honestly, I've not seen any difference in the two tracer. So I think that the only consideration is the feasibility. Of course, the synthesis of fluorine FAPi is not, I'm not an expert, but it was not easy for the radiopharmaceutics, for the radiochemists and radiopharmaceutics to perform the synthesis in the beginning. But now I think they have honestly the same time as for gallium FAPi. So if you have a cyclotron, I would suggest you to start trying to do the synthesis of fluorine FAPi, and then you will see, because it's always easy, better to save the generator of gallium.
Thank you so much. ¿Hay alguna otra pregunta? I think it's everything. Thank you for having us here. And we see you soon.